spent many years of my life working for the World Health Organization, but now, as you can see from this front slide, I'm far away. My presentation will follow a little bit what Professor Cloninger was talking about. It will be in the spirit of positive psychology. So what I will try to do is to put a question mark on these three states: normality, abnormality, and mental illness. And the question mark will be whether these three states are points on a continuum or three distinct and categorically, to use nosological language, divided states with clear boundaries between each other. So, what is normality? Well, there are very many different ways to look at normality, and one of them is, of course, an epidemiological approach. And if we look at normality from the epidemiological perspective, having psychological characteristics that are shared by majority of people in a population, culture, and at given time would be normal or being normal. Another way is to look from a socio-cultural, or if you wish, ethical-legal point of view, and then being within socially agreed limits, the defined range of normal functioning, don't steal, don't kill, etc., would be normal. Finally, medical or clinical approach simply says that if you don't deviate significantly from what's considered to be average, you are normal. So, normality can be seen as an average, being like everybody else, i.e. being within the mid-range of bell-shaped curve of normal distribution. Alternatively, you can take Jungian view that normality is an ideal striving towards self-realization, individuation, self-improvement, trying to be a better person could be seen as, well, a normal thing to do. Also, normality can be seen as being well adjusted, being able to cope with life, fulfill social roles and goals expected from you in the culture and society you live. Now, this is my modest attempt to define what is or who is a normal person. Well, in my view, efficient perception of reality, realistic view of our strengths and weaknesses is an integral component of being a normal person. Self-knowledge, understanding why we do things and have certain emotions is also an important component. Our ability to control behavior and impulsivity is certainly important. Having self-esteem, knowing our value, and feeling happy with our achievements, and Professor Cloninger alluded to it, is also part of, well, normal or healthy personality, as he was talking about. Ability to form close relationships, needless to say, is a part of being normal. And finally, being productive, channeling our energy into work and social life is important. Now, moving along that spectrum is looking at abnormality. Abnormality usually has a negative connotation. Abnormal, not normal, means anomalous, aberrant, improper, deviant, even sick, odd, unusual. Now, deviation from social norms can be in many different ways, in terms of appearance, the way you are dressed, your lifestyle can be alternative, living situations. Tramps come to mind as people who are in between, well, between what's normal and perhaps mentally ill. Various maladaptive behaviors such as drug use, damaging passions and habits, promiscuity, gambling, that do not meet ICD and DSM criteria for a mental disorder are in between. Personal distress, people who have irrational fears, who worry a lot, who are dissatisfied, who are angry, but do not belong to anxiety disorder spectrum of our current classifications, are maybe in between. Abnormality, of course, depends and changes across time and space lines. Being selfish might be normal for a child, but is certainly not normal for an adult. Premarital sex was a no-no many years ago, nowadays not an issue at all. Cannibalism in certain situations, almost, well, survival mechanism, but otherwise not very normal. Killing, you get decoration in Afghanistan, elsewhere you get in prison. Now, culture plays a big role in how we see what's normal and what's abnormal. But which culture? Culture that we live in, like local culture, like Geneva culture, like Perth culture? What about Aboriginal people who are really the locals in Australia? Should we all take in, I don't know, their views, which are very alternative, as a baseline? What about migrants? Not both. Many countries nowadays have many migrants. So these migrants should be measured in terms of normality or abnormality using what yardstick? Their own culture or culture of the society they moved in? Or should we develop a global measurement because we live in a global world, and to be normal is, well, to speak English, be able to use computer and have, I presume, driver's license. Now, moving further along that spectrum is, of course, to look at mental illness. This is a typical, this is Western Australian Mental Health Act, so medical legal definition of who has a mental illness. If the person suffers from a disturbance of thought, mood, volition, perception, orientation, memory that impairs judgment and behavior to a significant extent, he or she meets criteria for mental illness. But the same act also says what's not to be considered mental illness. So if only one or more of these, if the person holds or refuses to hold a particular view, be it religious, political, philosophical, or other, that's not to be considered mental illness. Sexual promiscuity or particular sexual prevalence outside of mental illness field. If certain acts are just immoral and indecent, but do not meet criteria for diagnosis, they are not to be considered mental illness. Intellectual disability, taking drugs and alcohol, or antisocial behavior that do not meet diagnostic criteria, again, are not to be considered mental illness. Nowadays, we still use DSM-4 till, I don't know, May, when the DSM-5 will appear, and this is what we use to make psychiatric diagnosis. Now, what is diagnosis in medicine and psychiatry? It's a statement that requires or specifies symptoms, signs, their onset, duration, reaction to treatment, course and outcome. The main purpose, and we often forget that, of ICD and DSM diagnosis is really communication between health and mental health professionals and statistics, WHO statistics of mortality and morbidity. That is what both ICD-10 and DSM-4, which are called statistical classifications, do. Now, if you use these classifications as textbooks or Bibles in quotation marks, their reliability and validity are, well, limited, sometimes dubious, and certainly arbitrary. On utility of these two classifications, there are divided views. Some people consider them to be death of psychiatry, or of that beautiful psychiatry and psychopathology that we used to like. Others point out that there are so many misuses of these two documents in terms of education. Residents and registrars think that if something is not in DSM-4, it doesn't exist. It's of course used in, by lawyers and by pharmaceutical industry for a variety of dubious purposes. Now, if you look how we make psychiatric diagnosis, really symptoms and signs of mental disorders as listed in these classifications are nothing else but points on a spectrum ranging from, well, normal to psychopathological. They're really part of normal behavior, and only if they cause personal distress, person is suffering, or person cannot fulfill their roles, social or professional and other roles and obligations, and if that behavior or symptom or sign is not accepted by the culture, then can it count towards diagnosis. But what's not diagnosis in psychiatry? As I already alluded, deviant behaviors, or some culturally accepted beliefs, like in Australia where I live, Aboriginal people believe that people physically die, but their spirits are well and alive and around, and if somebody hears a voice of a dead relative, that's quite all right. The whole culture accepts that as being normal, so that should not be used as an auditory hallucination towards diagnosis of, let's say, psychotic illness. And then there are a lot of examples of medicalization of more or less normal behaviors which ended up in our diagnostic classifications. And some of them are quite funny, that, you know, jet lag and road rage and whatnot, pathological jogging should suddenly become mental illnesses. Some people put a question mark on various physiological life change, life cycle, if you wish, conditions such as premenstrual and menopausal difficulties. Why should they be part of psychiatry? Narcissism, well, it is an odd kind of personality trait, but in certain parts of the world, maybe Los Angeles or somewhere else, you need it if you want to survive. Alternative life choices, homelessness, polygamy, etc. Well, some people do it, but why should that be part of psychiatry? And also, there are a lot of comments that, you know, naughty children for whom parents do not have much time because they both work and, you know, build their careers, suddenly become, I don't know, worry of us working in the mental health field. So, to finish, what is normality? According to this little fellow, he says normality is relative. Insofar as relative to my relatives, I'm normal. Well, perhaps. How to achieve normality? What should we do in this person-centered world to be more normal? Well, this is yet another personal attempt, my own attempt to achieve something towards normality. First thing, count your blessings. Practice acts of kindness. Savor life joys. Thank a mentor. Learn to forgive. And Professor Koninger already alluded to that while talking about that personality cubicle kind of diagram. Invest time and energy in family and friends. Certainly develop strategies for coping with stress and hardships of the day. And hopefully enjoy this meeting like I've been doing it. Thank you.